All right, so we'll go ahead and get going. Hello, everyone, and welcome to another special event for the colorectal series, virtual education series, I should say. Today's another one of our live mock oral series for the boards. As we mentioned a few weeks ago, we have partnered with our colleagues from Behind the Knife, and our event tonight is being recorded and should be able to be accessed on their website in the next few days. My name is Rishi Batra. I'm a colorectal surgery fellow at Mayo Clinic, and I'm part of the leadership committee for CRS virtual education series. I'll have some of my colleagues introduce themselves as well that are also in the leadership committee. Then we'll introduce our two examiners, Dr. Carrie Peterson and Dr. Samuel Eisenstein. And we'll have our two examinees, examinee 1 and examinee 2, get going with our mock orals today as well.
Hi, everybody. My name is Jennifer Miller OQN. I'm another one of the leadership committee members. Welcome, everyone, and we appreciate you being here tonight. As an aside, if anyone is interested, preferably someone who's going to be a first-year fellow next year that might be on the talk, is interested in becoming a leader of this committee, please send an email to us at colorectal.educational.series@gmail.com, and we'll be posting more on our website. So thank you.
And I'm Ben Goff. I'm another member of the committee. I'm a current colorectal fellow down at Baylor in Dallas, and I'm glad everyone's here and joining us.
I don't know if Poonam's on the call, but we'll go ahead and introduce our two examiners tonight as well. Dr. Carrie Peterson and Dr. Samuel Eisenstein should be joining us. Dr. Peterson is an associate professor of surgery and is a colorectal surgeon at the Medical College of Wisconsin. She did her general surgery training at University of California in San Diego, followed by 2 fellowships, one at Sloan Kettering in colorectal oncology, and then followed by colorectal surgery at New York Presbyterian Cornell Medical Center. Dr. Samuel Eisenstein is associate professor of surgery at UC San Diego. He did his general surgery training at Mount Sinai, followed by colorectal surgery training at Mount Sinai as well. Thank you to you guys for volunteering as examiners tonight, and thank you to our examinees, examinee 1 and examinee 2, for joining us tonight for our live colorectal boards. Thank you.
Thanks everybody for being here tonight. Dr. Eisenstein hopefully will be joining us shortly, so I'll go ahead and run the first session. If you enjoyed tonight's experience and would like more mock oral education, I just would like to highlight that the Young Surgeons Committee of ASCRS does put on an in-person mock oral exam. It's scheduled for May 4th this year, which is Wednesday of the conference, from 7 to noon. And it's about an hour and a half of examination time, and then an hour and a half of some talks and lectures that are really geared towards things that you want to know about, like how to negotiate your contract, things to think about when you're setting up your practice, how to approach, teaching when you're still trying to learn as well, and getting started in your practice. So lots of real practical things that folks have found useful in the past. So please go ahead and register if you are interested and able to come. We'd really love to have you there. So today, I think what we'll do for format is I'll do 3 questions, and then we'll spend a few minutes talking about the answers and giving some feedback. And hopefully then Dr. Eisenstein will join us in here for the second round. So be a little patient with me, because I'm going to try and take some notes while we do this so that I can provide you guys with some feedback on the scenarios that we'll talk about. All right. And we'll do about 6 minutes per question so we can kind of simulate the pace of what it'll be like for the real board exam, which is a little bit faster paced than the general surgery boards for those of you who've already taken that. All right, so examinee number 1, we will go ahead and get started. So the first question, this is a 64-year-old gentleman who is seeing you in the office, having been referred by his primary care physician for complaints of bleeding with some of his bowel movements that's been occurring over the last 3 months. He also notes that he feels there's some lumps that are happening whenever he has one of these bowel movements.
Okay,
I would go and examine this patient. I would also ask him if he's had any significant past medical history, including any abdominal surgeries, if he has any, takes any blood thinners, and if he notices that the stool is mixed in with the blood or appears to be coating the blood.
He doesn't have any past medical history, past surgical history. He's not on any blood thinners. And he says it's not really mixed in. It kind of like streaks the stool, and sometimes it drips, but it doesn't always happen. It sort of comes and goes.
Okay, and then I would proceed with a physical examination, focusing on the abdomen and also anal rectal exam in the office.
He is a little bit overweight, got a nice rotund abdominal exam, but it's otherwise unremarkable. There's no masses there or tenderness or anything. And on the anoscopic exam, you can see some small non-thrombosed external hemorrhoids. And on internal exam, you see some grade 2 to 3 internal hemorrhoids that are a little bit irritated and inflamed, but there's no evidence of any active bleeding.
Okay. I would have this patient started on medical therapy for those hemorrhoids with making sure that he's having 64 ounces of water, making sure he's not straining when he's having bowel movements, increasing his fiber intake. And also I would ask if he's had any colonoscopy before. And
he's not had a colonoscopy before. He also asks you, what do you mean by increasing my fiber intake?
So the goal for him should be 35 grams of fiber per day. He should not be straining when he goes to the bathroom. And also I would investigate if his bowel habits, making sure he's not spending a lot of time sitting on the toilet and straining as well.
Okay.
I would also refer him for colonoscopy.
Okay, good. So he gets his colonoscopy and it is normal other than some of the enlarged hemorrhoids as we discussed. And he comes back to see you in the office about a month after finishing his colonoscopy. And he says, you know, it's a little bit better, but it's really not gone away entirely.
Okay, I would repeat my exam there in the office and evaluate those internal hemorrhoids.
They look pretty much the same.
Okay. At this point, you know, if he's failed medical therapy for this grade 2 hemorrhoid, I would perform rubber band ligation in the office for him.
What other options are there for hemorrhoid treatment?
He can also undergo, if it's only been, I forgot what he said, if it's only been 4 weeks, we could continue medical therapy. Also, he can undergo hemorrhoidectomy if he prefers, but I would start with more conservative management.
And what are the risks of this procedure that you would tell him about?
So there's a risk of bleeding. There's a risk of stenosis from the hemorrhoids. There's also a risk of pelvic sepsis if there is any infection after the procedure.
So you go ahead and you do the rubber band ligation, and he calls your office the next day and he says, oh my gosh, I'm in excruciating pain.
Okay, I would direct this patient to the emergency department where I would then evaluate him. I would get a set of vitals on him and see if I would send off a set of labs, including a CBC, basic metabolic panel, type and screen, and coags, and I'd also attempt a bedside examination.
So you do an exam and you can see a bit of thrombosed and necrotic looking tissue just at the dentate line where you put your rubber band in. It's really painful though to even get that look.
Yeah. Yeah, I would also check his vitals, and I would be pretty concerned because of his that necrotic tissue and his pain. Does he have any fever, tachycardia, or leukocytosis?
He's a little bit tachycardic. His leukocytosis is elevated to 18.
Okay. I would start him on IV fluids and also IV antibiotics. And I would talk to him about what I think is going on. I would consent him for an exam under anesthesia in the operating room, and also incision and drainage of any abscess or debridement of necrotic tissue.
Okay. We'll move on to our next question. So this is a 64-year-old woman who comes into your office complaining of hemorrhoids. She states that she's had constant worsening anal rectal pain. Excuse me, hold on, let me set my timer again. Here we go. For the last 2 months, and has experienced occasional blood in her stool and sometimes spontaneous bloody discharge. She has developed some incontinence over the last 2 weeks and has noticed some anal itching for the last several months.
Okay, I would also talk to this patient about her bowel habits, if she has any constipation. Also, I would review her past medical and surgical history, if she takes any blood thinners, NSAIDs, or has had any colonoscopy previously.
She has had a colonoscopy. It was about 10 years ago. It was normal. She doesn't have any real significant medical history. I'm sorry, what else did you say?
Yeah, that's all. If she takes any medications.
Oh, nothing significant.
Okay, then I would proceed with a physical examination, including abdominal exam and anal rectal exam.
So on abdominal exam, she's slightly overweight, but otherwise unremarkable abdominal exam. On rectal exam, you can see that there is an ulcerated tender mass in the left lateral aspect, kind of peeking out from the anal canal. It's very painful for her to have the exam, but you can get your finger in about 1 centimeter or 2 on digital exam, and you don't reach the proximal extent of this mass.
Okay, and at this time I would, how long has she been having the pain? I'm sorry.
The pain has been going on for about 2 months.
Okay, yeah, I would send off a set of labs for this patient, and also refer this patient for a complete colonoscopy as well.
Okay. What kind of labs would you get?
I would get a CBC, basic metabolic panel, and coags. And also in the meantime, if this is a hemorrhoid, I would have her undergo sitz baths, increase her fiber intake and water intake as well.
So she goes to get her colonoscopy and she comes back, and that was the only thing that was abnormal. But the gastroenterologist was concerned about taking a biopsy because it's pretty far distal, and so he didn't biopsy it.
Okay, I would take this patient for an exam under anesthesia and possible hemorrhoidectomy. I would further evaluate this lesion, see if I believe it is in fact a hemorrhoid, and yeah.
So you take her to the operating room. You can see this ulcerated lesion at the dentate line extending to the anal verge. It goes about 1 centimeter proximal to that as well, so the length of the anal canal. You start sort of on the anal margin to raise it up, but it's pretty stuck to the muscles underneath, and you really can't get a good plane underneath it.
Sure. In that case, I would biopsy this mass and leave that alone and see her back in the office for follow-up of that biopsy.
So the biopsy shows moderately differentiated anal squamous cell cancer.
Okay, for this, I'll talk to the patient about the diagnosis and the treatment. I would first send her for staging with CT, chest, abdomen, pelvis. I would also examine her groin for any enlarged lymph nodes, and also send off a CEA.
So the CEA comes back normal. The inguinal exam is unremarkable. And the CT scan shows this thickening in the anal canal. There's a couple of perhaps enlarged mesorectal and lymph nodes, but otherwise nothing remarkable or concerning for metastatic disease.
Okay, so this patient has squamous cell carcinoma with no evidence of metastasis. Sounds like it's about one centimeter. So this would be a T1 lesion potentially. For this, I believe the patient would undergo wide local excision of this lesion.
How would you do that?
I would take the patient to the operating room and place her in the lithotomy position. I would use a lone star retractor to visualize the anal canal properly, and then I would score around this lesion, and then take a full thickness excision of that, and then close the defect.
Okay, we'll move on to question number 3. So this is a 25-year-old man who comes in to see you with a 10-year history of Crohn's disease. He had presented to the ER with some abdominal distension, nausea, and vomiting, but he's no fever. He is on Remicade and 6-MP currently.
Okay, so this patient has Crohn's disease and seeing me for distension, nausea, and vomiting. I would evaluate this patient with physical examination, including abdominal exam, checking for any hernias, and also perform a rectal exam.
So the abdominal exam is significant for some distension, some tenderness in the right lower quadrant, but he's not peritoneal. And you said what else did you say? I'm sorry.
I would check for any hernias and perform a rectal exam as well.
Perfect. He does not have any hernias, and his rectal exam is unremarkable, and there are no lesions or fistulas on his perineal skin.
Okay, I would send this patient for a CT abdomen pelvis with IV and oral contrast.
So you get a CT scan of his abdomen and pelvis that shows some significant thickening in the terminal ileum. There's proximal dilation all the way proximally to his stomach. His stomach is dilated as well, but there's really, a little bit of stranding in the area, some scanticides, otherwise nothing remarkable elsewise.
Okay, so it sounds like this patient has a stricture associated with his Crohn's disease. I would also talk to GI if there's any role for steroids. I would also talk to this patient and see if he's having an acute flare of his Crohn's disease to treat that conservatively.
GI is on vacation.
Mhm. Okay, yeah, I'm sorry. In the history, was this patient, how long has he been having this pain for, and had he been taking any steroids?
He said it started about a week ago. It has been getting progressively worse. He's not currently on steroids. He's taking Remicade and 6-MP. He's been on steroids in the past when he was first diagnosed with Crohn's disease 10 years ago, but it's been a long time since he's
Okay.
acquired any.
Yeah, I would attempt to treat this Crohn's flare with oral steroids.
Anything else you'd like to do?
I would also send off labs for this patient, including a CBC, basic metabolic panel as well. And yeah, that's all.
So it's the next day and the patient is vomiting and his urine output is a bit low.
Okay, yeah, I would refer this, send this patient to the emergency department. I would have him get vital signs. I would place 2 large bore IVs to start IV fluid resuscitation, and also start him on IV steroids. I would also place a nasogastric tube for decompression. And yeah.
So you do all of those things. He feels a little bit better with the NG tube in. He stays overnight in the hospital, and the next day he spikes a fever.
Okay, yeah, he also needs antibiotics.
So you put him on antibiotics, and he tells you that, gosh, this right lower quadrant pain is actually feeling quite a bit worse now.
Okay, I would be concerned about this patient having refractory Crohn's flare. And I would talk to this patient, and also, if I haven't also started him on IV steroids, I would have done that while he was an inpatient. And I would also talk to him about surgical intervention for this Crohn's disease.
And what kind of surgery would you offer him?
I would offer him a laparoscopic ilio cecectomy.
And describe how you would do that surgery.
Okay, I would have this patient have a Foley catheter. I would take him to the operating room and supine position. I would gain access to his abdomen using Hassan port. I would place 2 ports on the left side of the abdomen. I would evaluate his terminal ileum and cecum and the extent of this disease. I would grasp the cecum where it appears soft and mobilize the cecum along the white line of Tolt. I would then create a window behind the cecum and transect the cecum, and then I would find a portion of healthy bowel in the terminal ileum, create a window beneath the terminal ileum, and then divide the mesentery using a ligature, and then perform an anastomosis.
Okay, well, we'll stop there. Thank you for letting me torture you for the last 20 minutes. So kudos to you for taking that for the team. I would say, please remember overall, just as general, to don't forget about the focused history questions, right? So like things for hemorrhoids is, you know, especially with bleeding, like what's the family history? Have they had this before? You know, I didn't offer if they had pain or not, but a good question is to ask if they have pain, because that can help differentiate whether they had a fissure versus a hemorrhoid, right? So you can kind of get an idea on that. You did really good with, the water and the toileting habits and the fiber recommendations and all the medical behavioral management stuff beforehand, which was excellent. You remembered to ask about the colonoscopy and referred him for that. So good for remembering that. I would say, when you are going through these exams, it's really good to talk through what you're thinking a little bit and to be like, okay, so this is a guy, he has mixed hemorrhoids, external and internal, right? His main symptom is bleeding. He's failed medical management. There are a few different ways we could address this problem for this patient, right? One option is rubber band ligation. One option would be THD, right? One option would be a PPH as well, because they're all three going to really address the internal components. And then, you could say the other option would be an excisional hemorrhoidectomy as well, to get rid of the external components. And while that's not his primary symptom, it certainly is an option available. And so you can talk through all those options. And then it kind of tells the examiner, you sort of, what you're talking about, so to speak, right? So that would be a good way to answer a question like that, because then you can say, oh, and this is why I would pick rubber band ligation. His primary symptom is is bleeding. They're not very large. He's a good candidate for a rubber band ligation. So that would be a great option. And then, yeah, I gave you that he has a excruciating pain afterwards, and you did the appropriate thing to send him in to get them evaluated and, worked up for pelvic sepsis after the rubber band ligation. So thank you for catching that. That was good. The second one on the anal cancer, I described it as an ulcerated mass in the anal canal, which probably should have pushed you into taking a biopsy when she first showed up, to be perfectly honest, and asking more of her personal history, smoking history. For women, have they had any abnormal cervical paps in the past as a risk factor, or any other known HPV exposure? Are they HPV vaccinated? She probably isn't. I think she was 60 or something like that. But for a younger patient, that might be something you want to ask. And kind of delving into that a little bit, because it can give you a bit of a history of what's going on. Recommending sitz baths and fiber for temporizing her symptoms. It isn't wrong, but it's probably not going to really make a difference, obviously. And then the examiner anesthesia I described it purposely invading into the sphincters so that you wouldn't try to take it all out. So I'm glad you caught that and didn't do that, because clearly that would have been a problem. But I think from a staging standpoint, the other thing that we will almost always get is an MRI of the pelvis for staging anal cancer. And it is much more accurate at looking at lymph node metastases than just a plain CT scan. So don't forget about that. Some people will even order PET scans. We actually pretty routinely look at PETs as well to pick up inguinal lymph nodes that you may not be able to appreciate clinically. So just a heads up on that. And then wide local excision. So if it were a much smaller T1 anal canal cancer, you can treat them with wide local excision, but they do have to be really small, and they certainly can't be invading into the sphincter, right? Because you do need to get a deep margin that's clear. So if they're anal canal of any kind of depth, really chemoradiation therapy is going to be your treatment of choice. It's a very select patient that's going to be a candidate for wide local excision with an anal canal. We can be more tolerant of anal margin cancers, excising those, right? Because it's easier to get a margin around those. So just kind of make sure you keep those two things differentiated when you're talking about anal cancer, because they are treated a little bit differently. So, and then the last one on the Crohn's patient, he was in the ED already. So I was trying to get you to do the NG tube, IV fluids, decompression, treat him like a small bowel obstruction, and medically manage his Crohn's disease first. to kind of work through that inflammatory obstruction that he had. The other thing that I would make sure to ask you asked the questions about his history really nicely, so that was good, and circle back to ask those detailed questions. Make sure you get inflammatory labs like a CRP and an E as well, okay, when you are checking for Crohn's flares, essentially. And the other thing would be to check a Remicade trough and trough level to see where he is. Maybe he's subtherapeutic and you could adjust his dose as well. So a couple of little things there as well. And I was trying to get you to, my ultimate goal was to get you to rescan him and him to have an abscess, but we talked about surgery instead. So, and then we ran out of time. So that was my on that.
I'll give, I was taking some notes as well, Carrie, so I'll jump in. I think just a couple of sort of holistic comments. I think your pace is good and you move through, cases well. I think just try and keep the order of things straight. So there were a few times where you were given information about the exam or imaging, and then you'd go back to the history. And so one thing that's a nice trick to let the examiners know that you're following along is you can summarize the case, once they give you a certain piece of information, and then maybe as you're summarizing, you can say, one thing I would have wanted to ask in the history that I didn't get a chance to ask. And then probably the other comment I'll just make is, you were given that the patient developed a fever. So change in clinical course for patient, I would say, go and examine them, reassess, rather than just sort of saying, okay, I'm going to start antibiotics. What's their exam? Maybe a fresh set of vital signs, fresh set of blood work as well.
Yep.
Thank you.
All right, thank you, Dr. Peterson. And with that, I guess we'll segue into our next examinee 2. Dr. Jonathon Abelson will be examining her. He is assistant professor at Lahey Medical Center. He did his general surgery training at Cornell Medical Center, followed by colorectal surgery at Washington University in St. Louis. Thank you, Dr. Abelson and examinee 2 for joining us this evening, and we'll turn it to you guys.
All right, Dr. Vu. So you're called to the emergency department to see a 78-year-old male. He has a sudden onset of left-sided abdominal pain and some bloody bowel movements for the past 24 hours. He has a history of hypertension, coronary artery disease, CHF, has an ejection fraction of 30%. No prior GI history. Last colonoscopy was 2 years ago and was normal. No other relevant history. On exam, his heart rate is 105 beats per minute, but otherwise his vitals are normal. And on examination, his abdomen is distended. He has some focal tenderness of palpation in the left upper quadrant, but no peritonitis, no rebound tenderness or guarding. Rectal exam shows no palpable masses, and stool is guaiac positive. How would you like to manage him?
Thank you. So you've given me the history. I'll ask if he's on any blood thinners.
Yeah, he's on aspirin 325.
Great, thank you. And then I will go ahead and get a set of labs, including a CBC, a CMP, and a coag panel.
Okay, so white count's 25,000, creatinine is 2.5. You get a lactate, which is normal.
And could I get a set of vitals? And I would go ahead and establish IV access and give him some fluid.
Yeah, so you get the vital signs. So afebrile, heart rate is 110, respirations are 25, blood pressure is normal. You get your IV and you give some IV fluids.
Great. I think the next thing I'd like to do is start with imaging. So I would get an acute abdominal series. Okay,
and what are you looking for on that?
I'm looking for free air, as well as to look at the distribution of gas in his bowels.
Okay, so no free air and is a non-obstructive bowel gas pattern.
Okay, then the next thing I'd like to get is a CT of the abdomen and pelvis.
Okay, what's on your differential at this point?
So he's got bloody bowel movements. He did have a normal colonoscopy 2 years ago, but he certainly could have a malignancy. He could also have diverticulosis that's bleeding, or an episode of diverticulitis, although that would be unusual to have bleeding with that, but some kind of infectious process given his white count as well.
Okay, and so what kind of CT do you want?
A CT of the abdomen and pelvis with PO and IV contrast.
Okay, and so his creatinine was 2.4. His baseline is 1. Do you still want to give him IV contrast?
I think in this case, I would still want to give him IV contrast.
Okay. So you get your CT abdomen and pelvis, and it shows segmental inflammation and some thickening of the left colon. Some pericolonic fluid, no perforation, no obvious masses, no drainable abscess.
Okay, I would go ahead and have him get a colonoscopy, and I'm suspicious now of ischemic colitis.
Okay, so you're going to give him a bowel prep?
No, I'll just go ahead and have him have a colonoscopy.
Okay, and what are you looking for with that?
Looking for signs of mucosal ischemia and any sign of compromise of the bowel.
Okay, so you see some mucosal inflammation and hyperemia starting around at the descending colon and extends in a continuous fashion towards the distal transverse colon. Not a great prep, and so you stop at the mid-transverse colon, no overtly necrotic segments of bowel.
Okay, so in this patient, it seems as though he does have ischemic colitis, so I would start with supportive care. So I would give him bowel rest, make him NPO, and give him IV fluids, and I would treat him with IV antibiotics as well.
Okay, so you do that, you admit him to the hospital, serial abdominal exam, and let's say that on hospital day 5, he develops a fever to 39 degrees Celsius, and he's newly hypotensive to 70/50 and has worsening left side of the abdominal pain.
So I would go see the patient and get a new exam, but he does sound sick, so I'd be concerned that he would need an operation at this point.
Okay, so you go and see him, and he looks ill, and so you said you're going to take him to the OR?
Mm-hmm.
So what are you going to do in the operating room?
So I would assess him. I'm worried that his ischemia has progressed, and I would talk to him about if I find a segment of ischemia, I would resect that portion, then bring up a loop of, bring up a colostomy.
Okay, so you get into the operating room and you find a perforation and a necrotic segment of bowel at this point, flexure. So you said you're going to do a resection, and then what?
And then an end colostomy with a rectal stump.
Okay. All right. So now you're in the office and you're seeing a 63-year-old male. He recently underwent a colonoscopy for iron deficiency anemia, and that revealed a 3-centimeter fungating mass at the hepatic flexure. The endoscopist performed a biopsy, placed a tattoo in all 4 quadrants 2 centimeters distal to the mass. The pathology does return as moderately differentiated adenocarcinoma. This was a normal surveillance colonoscopy, completely asymptomatic, has 1 bowel movement per day, no signs of obstruction, has hypertension, takes lisinopril, no other medical or surgical history. The rest of his history is unremarkable. How are you going to manage him?
I would counsel the patient that he has this malignancy and we're going to work it up. And so I would get a set of labs, including a CBC and a CMP. And then I would also want to get staging studies. So a CT abdomen and pelvis and a CEA, a chest abdomen and pelvis and a CEA.
Okay, so you're in the office, so you order all of that stuff. What are you going to do for him in the office?
I'll do an exam and see what his exam is like, as well as a rectal exam.
Okay, so abdominal exam is benign, rectal exam is unremarkable. So you get your blood work, which is all completely normal. CEA is completely normal. And then you said you're going to get some imaging.
Mm-hmm.
And what kind of imaging do you want?
I would get a CT chest, abdomen, and pelvis.
Okay, so no evidence of metastatic disease, and you can't see the mass on CT scan.
In this case, I'd like to take him for a colonoscopy myself. So I would prep the patient and then take him for a colonoscopy.
Okay, so you do the colonoscopy. You again confirm that there's a 3-centimeter fungating mass at the hepatic flexure. You see those tattoos that are just distal to the mass. Anything else you want to do?
Here, I would say, since we have tissue confirmation, then we can go ahead and take him to the operating room for a resection.
Okay, and what kind of surgery are you going to do?
I would do a laparoscopic extended right hemicolectomy.
Okay, can you talk me through steps of the procedure?
Mm-hmm. So I would place the patient supine, and I would perform a cut down incision at the umbilicus to place my first port, insufflate the abdomen, place my camera, and explore the abdomen, making sure that he doesn't have signs of metastatic disease. I would then grasp the cecum and skeletonize the iliacolic pedicle. And then I would perform a high ligation of the iliacolic pedicle, making sure not to injure the duodenum. I perform a medial to lateral mobilization of the colon mesentery, and then take the lateral attachments of the colon until I'd fully freed up the hepatic flexure until I get to the right branch of the middle colic. I would then make a periumbilical extraction port and pull out my specimen, and I would perform my extracorporeally.
Okay. And how are you going to manage him post-op?
I would have him on a enhanced recovery protocol. So I would advance his diet to a low residue diet, wean his IV fluids, wean his IV pain medicine. And when his pain is well controlled and he seems to be doing well, I would discharge him home. And I would send him home on expanded DVT prophylaxis.
Okay. All right. So you do that. He recovers well. The pathology returns as a T3N1 moderately differentiated colon adenocarcinoma. So what are you going to recommend now?
So I'd have him discussed at our multidisciplinary tumor board, but the recommendation would be for adjuvant chemotherapy.
Okay. And then what's that chemotherapy going to be?
That would be full.
Okay. And then are you going to do the surveillance yourself?
I think for this, he would need surveillance with every 6 months CT abdomen and pelvis, CT chest, abdomen, pelvis, and a CEA with exam. And I would split that with the medical oncologist per our protocol.
Okay. All right. So let's say that instead of him having a straightforward recovery, he is discharged home on post-op day 3 and then presents to the ER on day 7 with fever, nausea, vomiting, abdominal pain. You see him in the emergency department. He's tachycardic to 105, but his blood pressure is normal, breathing well, normal oxygen saturation, and he has some tenderness in the right upper quadrant. Surgical incisions are well healed. Otherwise, the exam is normal. What do you want to do at that point?
So here I'd be concerned of an infectious complication of the operation, and at the worst, an anastomotic leak. So I would make sure he has good IV access, start IV antibiotics and fluids. And once he stabilizes, I would send him for a CT of the abdomen and pelvis with oral and IV contrast.
Okay, so you get some IV fluids going, you give him antibiotics, you get some blood work, his white count's 25,000, creatinine's normal. CT shows a 5 centimeter fluid collection containing gas that's adjacent to the anastomosis. No evidence of oral contrast extravasation.
Since he is post-op day 7, and has he stabilized now?
Yes.
Since he's post-op day 7, I think I would not immediately take him back to the operating room unless he became sick. And so I would attempt to manage this non-operatively. I would ask my interventional radiology colleagues to place an imaging guided drain.
Okay, and let's say that they're not able to access this area and he has worsening pain over the next 24 hours.
His pain worsens and you said it was a 7 centimeter collection?
Yes.
Yes, I would take him back to the operating room at this point and inspect the anastomosis for a leak.
Okay, and let's say you find a 2 centimeter defect in the anastomosis.
I would go ahead and take that down, and then I would make him a double-barreled stoma.
Okay. All right, so you're called to the emergency department to see a 58-year-old male. He's had 5 days of no bowel movements. He does have a history of schizophrenia, lives in a nursing facility, takes Miralax and Docusate every day in order to have a bowel movement. And so this is definitely abnormal for him, is what his caretakers say. So on presentation, he has abdominal distension and poor PO intake, no fevers or chills, no known sick contacts. Otherwise, medical history is unremarkable. He had an appendectomy 30 years ago. He's up to date with colonoscopies. No relevant history otherwise. How would you like to manage him at this point?
Okay, so you've given me the history and the exam. I would get a set of vitals and a set of labs, including a CBC and a comprehensive metabolic panel.
Okay, so vitals are normal. Just to confirm on his abdominal exam, he does have abdominal distension, but no tenderness to palpation. No appreciable hernias, rectal exam is normal. His blood work is all normal.
Okay, so I would get a acute abdominal series.
Okay, and what are you looking for with that?
It sounds, a patient who has cognitive issues in a nursing home with distension could be a volvulus, a sigmoid volvulus, versus worsening constipation.
Okay, so you get an abdominal x-ray and it shows some gaseous distension of a loop of colon. A little bit difficult to make sense of everything because of how dilated it is, but it does appear that the axis is pointing to the right upper quadrant with decompressed rectum and small bowel.
Okay, right upper quadrant.
Yes.
Okay. So this, to me, is concerning for a sigmoid volvulus. And so I would make sure the patient's appropriately resuscitated and that his vitals are normal. And I would talk to him about attempting colonoscopic decompression of the sigmoid volvulus.
Okay, and so you do that yourself?
Mm-hmm.
Okay, so you're able to traverse the sigmoid colon, you do appreciate a volvulus, and you get a big rush of gas and stool. So what are you going to do now? So
at this point, I would try to decompress him, and then I would talk to the patient about performing a urgent sigmoid colectomy.
Okay.
Emergent.
Okay, and so what do you mean by that?
So we could wait for him to feel better symptomatically and decompress more fully, and then we can take him to the operating room for a colectomy.
Okay, and so that's 4 hours, 6 hours, 2 days, 4 days. What's sort of your time?
I would admit him and monitor him. I'd like him to have bowel movements, and maybe within the next 1 or 2 days that we do this operation.
Okay, would you give him a bowel prep?
If he is having consistent bowel function, I would.
Okay. And so then what operation are you going to offer him?
So I would do a laparoscopic sigmoid colectomy with a primary anastomosis. If he's been able to decompress and take a bowel prep, I would do that laparoscopically. Okay. And then any stomas? If depending on the quality of the bowel and he's not very the bowel is not very dilated, I would put him back together. Okay. All right, so let's say instead on his presentation, he's hypotensive, he has focal peritonitis over the lower abdomen, white count's 15,000, rest of his workup is normal, same x-ray findings. How would you manage him now? So now he sounds sick from his sigmoid volvulus. And so what I would talk to him about is doing an emergent exploration and resection of the sigmoid and trying not to detorse the sigmoid while I do it. Okay, so you take him to the operating room and you see ischemic sigmoid. There's no perforation. You don't detorse it. What are you going to do now? I would resect it. And in this patient, I would give him an end colostomy with a Hartmann's pouch. Okay, and then how are you going to manage him post-op? So I would have him, give him bowel rest until he starts having bowel function through the colostomy. And if he developed an ileus, I would place an NG tube. I would try to keep him euvolemic, and I would avoid opioids as much as possible. Okay, so he recovers from that and comes to see you in the clinic 6 weeks later, which with his brother is his healthcare proxy. And they're asking you about, when you can have his colostomy reversed. I would say if he wants his colostomy reversed, that's very reasonable. I would wait at least 3 months after the operation to do it. Okay. All righty. Thanks. Dr. Peterson, do you want to jump in?
Yeah, I thought you did a very good job. I liked that you paused to summarize and sort of say what you're thinking and say what your concerns were and what your differential diagnosis was. That sort of helps us appreciate that you understand kind of where things are going and what your internal monologue is actually saying. So I thought that was really good. For the first question, I think that the only real feedback that I had was, etiology of why he had this ischemic colitis, sort of figure out what might be going on there. But at least the initial management was appropriate, and then there wasn't any big red flags that I saw in that.
Yeah, I mean, I
Second
think,
one- Go
yeah,
ahead.
I'll just jump in. Yeah, I agree with you on that. I think, you could certainly discuss whether or not to give IV contrast with some of the creatinine 2,4, but I think, I think you can certainly defend it either way. But I think you managed that really well and responded to his the change in the status very nicely.
The choice of Hartmann's in an unstable patient is reasonable. Always remember that a primary anastomosis with the proximal diversion is an option as well, and a lot easier for people to get reversed than a Hartmann's. So, if they're not critical, it might be worth taking the extra time, and you can kind of talk through that scenario with your examiner as well. So.
And I think it's it's sort of you'll get different feedback, I think, from different people about how to approach this on the exam, because people can certainly talk in circles and say, well, I could do this, I could do this, I could do this. And so I think one thing that you did very nicely, just sort of overall, is you're saying, this is what I would do, right? So, and that's, I think, a good model. But there might be some room, as I think Dr. Peterson is saying, maybe to say one potential option is this, just to let people know you're thinking about it, but I would choose X for this reason.
Yeah, that's correct. Yeah, and yes, yeah, you don't want to talk in circles. Excellent point. The second question, I thought you did well on. You got all the staging workup. You described your operation appropriately. You recommended adjuvant chemotherapy, you recommended surveillance, all of that was good. I thought your description of surgery was good. I tell my general surgery residents, like, try to boil down an operation to 5 steps to say for these exams, so that you can be like, I'm going to do, A, B, C, D, E, and then be done. And if people want to ask you more details about, oh, well, tell me about what are the pitfalls that you're looking for when you're doing your medial to lateral mobilization? What are you watching out for? All the stuff about the duodenum and whatnot. You can then describe that, but at least it keeps things moving forward. So that's a good strategy for all oral exams, really.
Yeah, and I agree with that. I think, especially for colorectal surgery, talking about a few of the main pitfalls to mention the duo is critical. So, maybe you want to throw in there about margins, or what sort of, how you're deciding what proximal and distal is, and then talking about attention-free anastomosis.
The last question I thought you did well on as well. The colonoscopic decompression in a stable patient is a very reasonable option. The kind of key phrase for the timing of surgery is that hospitalization, right? Which I think Dr. Abelson was trying to get you to say. But usually it's that hospital stay. You want to get their surgery done. So whether it's, the next day or the day after or a week later, that hospital stay is sort of the key phrase that people look for with that. And then the second change in scenario where he was unstable and you recognized that and took him to the OR and didn't detorse it and all that was good. So I didn't have any other feedback. Again, another option, like a stoma in a guy with schizophrenia who might not be able to manage it well. Those are patients who tend to like pick at their stomas. Some might argue that putting back together may be a reasonable choice for a patient like that as well. So something to think about. I don't think either answer is wrong, but those are kind of considerations as well. Anything else, Dr. Abelson?
No, it was great. Good job.
Thank you.
Yeah, very good job. Excellent. Well, I just wanted to remind everyone, in case you missed it in the beginning, that we will do an in-person mock oral exam for the Young Surgeons Committee this year on May 4th. So the last day of the annual meeting. So if you're interested in coming and you'd like to register for that, please do. It's on the website. If you can't find it, by all means, email me and I can send you the link. cypeterson@mcw.edu is my email address. If you have any feedback about the scenarios or things we can do to help you guys in the future, please let us know. We're really interested in sort of facilitating your transition into practice and being here for you. So let us know. We don't have, there was a question from the chat about virtual. We are not going to do a virtual exam right now. We did one last year because of COVID and the meeting was canceled, but we are going to do it in person this year, so we don't have a virtual option. You know, if there's a lot of people who are interested in, we could consider doing one perhaps in the fall as a potential option. We'll keep you posted, but at least right now. Great.
Awesome. Well, thank you, Dr. Peterson and Dr. Abelson, for joining us tonight. We'll open it up to any questions from the floor. If anybody has any about the scenarios, I had a question for Dr. Abelson. The question about the sigmoid volvulus, about doing the bowel prep. What's the correct answer there? I don't know if I would have given bowel prep or not, and so I'm interested to know what the correct answer is.
I would, and I don't know that there's necessarily going to be a correct answer, but I think other options is, you know, leaving a decompressive rectal tube. You might hear some people talk about. I think the key point is making sure that they're having ongoing bowel function. And then, yes, you're waiting for them to decompress. And so I would say at that point, they should be able to tolerate a bowel prep. If they can't, there might be something wrong and they've revolvulized, but I would.
Perfect.
Yeah, I agree. I'd try to gently bowel prep them over a couple of days is my usual strategy for these patients.
Awesome.
Would you bowel prep the ischemic colitis person? The stable one? Okay.
Nope.
You could consider enemas. That might be the only thing you might want to do just to clear the distal colon or the distal rectum, but I wouldn't give them an oral bowel prep.
Perfect.
Yes.
Well, thank you to, I guess, examinees 1 and 2 for joining us and being volunteers for us as well. We really appreciate that. And then, of course, Dr. Peterson, Dr. Abelson, for giving us your time and expertise. We had a great turnout again tonight, and we're very thankful for our partners with Behind the Knife. And if you're looking for more great content, you can check out some of Dr. Abelson's other scenarios on Behind the Knife's website as well. Dr. Peterson kind of mentioned the ASCRS Young Surgeons Committee. You know, Dr. Jennifer Davids is who heads that committee and helps us connect with Dr. Peterson and Dr. Abelson. So thank you to them and for, you know, mentioning the mock orals coming up here in a few months at ASCRS. And hopefully we'll see everyone at ASCRS if we can here in the next few months. We're excited to have the meeting again. And with that, if there's any other questions, we'll open up the floor again. But we also want to be respectful of your time, and we appreciate everything that you did for us tonight. So.
Great, thanks.
All right, no other questions. Thank you.